Welcome to the EAU Podcasts. In this episode, UROONCO Bladder Cancer Associate Editors Dr. Mertens and Dr. Grobet-Jeandin talk to Professor Dyrskjøt on ctDNA in muscle-invasive bladder cancer, plus some fun rapid-fire questions for Professor Dyrskjøt.
Hi everyone, I'm Laura Mertens, and together with Elisabeth Grobet-Jeandin, we'll be discussing one of the hottest topics in urology at the moment, at least in our opinion, and that is ctDNA. Together with us is Professor Lars Dyrskjøt, one of the leading experts in this field from Aarhus University. Welcome, thank you for joining.
Thank you very much.
So let's start with the basics. For those who aren't very familiar with the ctDNA, could you explain what it is exactly and how come it has become such a big topic in urology?
I think the reason it's become such a big topic is that it's sort of a molecular handle we have on the disease. So the cancer cells are shedding DNA that's containing different mutations from the patient genome, and then we can use these mutations as sort of a molecular biomarker and molecular handle to actually track the disease and guide treatment based on that, hopefully.
And let's make it a bit more practical. So a patient gives a blood sample, and then what happens?
So what we've been doing in this is that we are making tumor-informed tests. So that means that we are looking for the exact mutations that we find in the tumor from the patient in the blood samples. Mm-hmm. So first we make a test based on the paraffin block, the tumor specimen that we have from the patients. And then based on that, we can make some very specific sensitive tests where we can track these mutations in the blood. So we extract the DNA from the blood, and then we look for these mutations in the DNA from this blood sample.
How much time does it take since you take the blood samples and you get the results?
It depends a little bit, and it depends on how the setup. We're doing it in a clinical trial in Denmark called Tombola, where we are testing patients for ctDNA after cystectomy, and if they are positive, they receive adjuvant immunotherapy. So we have a sort of a time window there of about 3 to 4 weeks. That's also because we have the time for this, because we developed the assays during the neoadjuvant chemotherapy also. So we can definitely do it faster if we want to.
And we've seen ctDNA moving from research into major clinical trials. You mentioned Tombola, there's also IMvigor11.
Yeah.
What have we learned from these trials?
I think what we've learned is that we have been moving from the prospective studies where we know that we can see that ctDNA is a highly prognostic biomarker. If patients are negative, continue to be negative, they have a superior outcome. If they're positive, they have metastatic disease. But what we've seen now from invasive and the first results from the Tombola trial also is that we can actually use these data or these results to guide treatment safely to the patients. So if they continue to be ctDNA negative in repeated measurements after cystectomy, we can safely avoid adjuvant immunotherapy in these patients and then only give it to the ctDNA positive patients. I think that's basically what we have learned from these studies, is that it is relatively safe. And of course, it has to be, they see a 95% recurrence-free survival at 1 year. In the IMvigor011 trial, we see a 97% recurrence-free survival in the Tombola trial after 1 year. So of course, that means that there are some that we are missing. Yeah. But we are also doing a major over-treatment of the other patients that maybe shouldn't have had the treatment also. So it has to be that balance also.
So then what's still holding ctDNA back from routine clinical use? Do you think it's more like logistical issues or maybe the costs?
I think what has been holding it back in Europe is the lack of randomized studies, the lack of phase 2 and phase 3 studies. So now we actually have demonstrated results that this is actually this has a clinical effect on the patients that we're doing this. So we have the results now where we can actually do it, so we can start to add it to the clinical guidelines in Europe, and then we have to figure out the reimbursement setup also, because it's of course different than the US also, who should actually pay for these tests. We have started discussions in Denmark about how actually to do this, and it's probably the local hospitals that are taking these the bills for this because they are then saving on some of the other treatments also. But I think that the reason it's not been used yet is simply because of the lack of clinical evidence that we can use this, where we actually go and guide the treatment based on ctDNA instead of just looking at prospective studies. And then, of course, there is the whole testing setup. So it's not mature yet. We need to have the possibility of using highly standardized assays in Europe, also CE-marked tests that we can actually purchase and use for the patients, but also have a high and a fast assay turnaround time. So it doesn't make sense if it takes months to get the results back. So we have to have this infrastructure built up also. But I think the first step is to have these results. We have the readouts now from these different trials in bladder cancer, and then the next steps are the clinical guidelines updates. If people think that they are adequate, the results to actually update the guidelines, and then from that start to think about the reimbursement and the clinical testing and all this.
RCTs first.
Yes.
Okay.
Yeah. Yeah, I think that's key. That's key to really demonstrate that it has a clinical impact to do this. We are seeing an improved survival in patients that are ctDNA positive when they receive the immunotherapy. So,
and beyond post-operative monitoring, do you think ctDNA could also play a role in the neoadjuvant setting or bladder sparing strategies?
It's of course it's a very important question now, seeing all these different new trials coming out. So I think the only evidence we have right now is in the adjuvant setting for immunotherapy. So I think that's important. But we also have the evidence in that space. So now moving into the whole perioperative setting and the new adjuvant setting, and when we start to see the results from Niagara and EV303 and these different new studies are going to be implemented, the results from that, I think we need to find a way to bridge the data we have from the adjuvant setting into the new adjuvant setting. So we're not there yet. We don't know how to act on a test that's positive or negative when the bladder is still intact. And so I think we need more data in that space.
How would you ideally incorporate ctDNA within neoadjuvant trials?
So it's a good question. So I think the first thing is to, of course, look at the prospective data we get from the trials. We have seen some ctDNA results coming out of Niagara. Mm-hmm. I think optimally we would have to design new trials where we use the ctDNA to actually guide the treatment in the neoadjuvant setting. That'll be the ultimate proof of this. But if we can somehow bridge between what we know in the adjuvant to the neoadjuvant setting, that will of course be optimal, because if we have to do trials all over again each time we have a new combination treatment or change the treatment a little bit, we'll never get into clinical use with these different. So we have to be, of course, have to be safe, but we also have to be pragmatic and try to learn from what we have already done and adapt that to other settings.
And don't do it over and over and over again.
Yeah, that'll be my hope, but I don't know if it's possible. But we'll. I think the first thing is, of course, to really learn from the studies where we haven't seen ctDNA as a sort of decision-making tool, but where it's been measured, and learn from that and see if we think that we can actually escalate or de-escalate based on those results, and then we'll have to take the next decisions.
That's a great overview. Thank you. Before we let you go, we have a couple of quick liar questions.
So to start easy, what's your favorite way to begin the day? Is it a slice of smørrebrød and coffee or a quick round of PCR analysis?
Yeah, that's another question. So I like to start the day with a cup of coffee and then start to...
And then PCR analysis.
So I'm... and then take care of some of the first emails and figure out where's the team heading now and where are we in different projects and so on. It's not that often.
Yeah. And your preferred sample type, blood or urine?
It's definitely blood, and that's of course it's it's very important for all the reasons that we've been talking about to get more knowledge about the urine testing also, but we also know that it's highly variable and it's highly heterogeneous, the results we get from that. So we need to learn more. But I think when we are talking about treatment de-escalation, bladder sparing in this setting, I think we really need to use the urine samples also. But the blood samples are, of course, more homogeneous and easier to work with.
Blood wins.
Yes.
What's your ritual before a big presentation?
It's a new question. It's I don't know if I have a ritual. Of course, I look at my slides and I try to prepare as good as possible, but not over-prepared, and take a deep breath.
Question, Roskilde Festival or a EAU conference?
I've never been to a Roskilde Festival, but...
So EAU.
EAU in that case,
Describe ctDNA in one word. Transformative, tricky, or to be continued?
Transformative.
And then finally, complete the sentence. In 2030, ctDNA will...
It will be a standard test for guiding treatment decisions in multiple settings in cancer patients.
Looking forward to it. Thank you very much for this interview.
Thank you.
Thank you.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU Podcast channel for regular updates.